that red line is going. We're recording. So we've known each other for a long time.
Yes, we have.
I was trying to put a number on it, like 25 years?
Fifth grade.
Fifth grade, so fifth grade.
So we were 10.
10, so 25 or 26 years. That's a long time.
Yep.
As it were, you're the third guest on this podcast.
And happy to be it.
But the first one that is a native Utahn. So other two individuals I had were not born and raised here. Yeah. So I got their kind of perspective of like what it was like coming to Utah and figuring out Utah. But as somebody that's born and raised here, I'm curious kind of like if you ever are insightful or reflective of like, oh, I was born and raised in Utah and that's great, or this is weird, or tell me your experience.
Yeah, no, I was born in Logan. Lived in St. George for a little bit when I was 3, but mostly just raised in Orem, Utah, center of Utah Valley. That's where we met. And yeah, I mean, I would say I wasn't super insightful like during the developmental years. Knew that I had a safe community, but wasn't really aware of much outside of that. We played soccer, so we would travel, to other places, but not in the context of really understanding what communities were like.
Sure.
Outside of Utah. I think going to college, got a little bit more exposure and everything, and ended up, serving an LDS mission that was out of the country, coming back. Then ended up living outside of Utah for grad school, and that's where I think I really started to understand the cultural differences. I remember previous to that in college once, somebody was like, it was in some upper level undergrad class, and they said, oh, we were talking about Utah sheltered, and they said, I'll bet you I can point out who was born and raised here in Utah. And I was like, okay. And he said, who knows what Bacardi is?
Okay.
Or no, it was who doesn't know what Bacardi is. And I was like, I raised my hand. I have no idea. I mean, I was back from my mission. So I was, 22, 23, and had no idea what it was. And raised my hand, they called me out. They're like, what do you think it is? And I just gave some answer. And then it was kind of this... they weren't doing it they were kind of doing it in a let's make fun of this person way.
Okay, yeah.
So I kind of, like me being me, I kind of pushed back. I was like, okay, so what does that mean to you? Just because I didn't know what that was, right? Mm-hmm. And so we had this conversation about, well, what does it mean to be sheltered? What does it mean to have an idea of what the outside community is? And it really brought to my attention at that time, just like, yes, there's things about the community I grew up in that means I don't have as much awareness to other things, and that's okay. Like Bacardi, that didn't make a lot of influence on my life, whether I knew that or not. But then there's other things where I learned living in Houston, a very diverse area, where I was very involved in the community and learning things. Man, I didn't know this about people. Okay. Because now I have this more diverse understanding of how people function. So then I also realized that there is this other side. Sure. That I haven't experienced, and I appreciated those experiences.
Yeah, I think I've probably experienced some similar things. So I think you're probably going on to maybe say to some level it was helpful for you to experience like the people level of it, maybe knowing what Bacardi is and not knowing what it is doesn't matter at some level other than for pop culture reasons or whatever, but right. But like understanding this different level of people, I think that's a very interesting thing. What was your main sort of insights or perspectives on that?
Yeah, I think what I realized was understanding people's diverse experiences brings a richness to my own understanding and how I relate to people. And that's very core to us as social beings. Yeah. Right? So the more I could understand that there are so many ways that people experience life and cultures help me be more empathic, help me be more patient. Even with people who are much more similar in our backgrounds and experiences, I still could transpose some of that to be like, man, I don't know what that was like for you, because I just learned that people have such different experiences to what I grew up with.
Right.
So I think it allowed me to see people as more human.
Okay.
Versus seeing them just through my own lens.
Yeah.
And it just allowed me to put on different lenses or try to, right? I can't put on a lens and understand somebody's culture perfectly, but be able to understand or at least appreciate somebody's experience.
Yeah, I think it's very interesting. You used the word kind of like seeing people as more human, and you were trying to kind of like, I don't know, put together what exactly that meant.
Right.
Yeah, me too. Like, I'm still trying to work that out. Like, because I think to some level, you know, growing up in Orem, Utah is even maybe a little bit more of a bubble than just compared to Utah in general. Yeah. So when at least when I was introduced to somebody that came from outside of the bubble, it was kind of like them being other a little bit, like the experience of being other. This is my place, Orem, Utah. You're coming in wherever you're from, and you're kind of seen as an other. Is that kind of what you mean in some sort of level? Is this other experience?
Other in the sense that I think I grew an appreciation that we're all other. Okay. Right? Like, we all have an other part of us in comparison to whoever we're interacting with. Yeah. And if we can both understand that and appreciate that and draw upon that to grow even just a passing relationship or a more intimate, in-depth relationship, that understanding that even in Orem, Utah, we all had different experiences in our households. And it might also be colored, but at the same time, during that kind of more exposure to differences and culture, I was also going through formal clinical training in grad school, so I was also being indoctrinated somewhat at the same time to how to help people who are struggling and how to understand somebody's background and how their experiences shape how they react emotionally and how they relate to other people and how they do or don't gain or maintain relationships. So at the same time, I was being taught from a clinical standpoint to understand how those things affect how people think and behave. So yes, I think that to the point that we're all different in ways, and our even similar experiences around us shape how we see the world and we see ourselves. Yeah.
So when you're saying your clinical training, your clinical psychology. Yes. So the age-old question in psychology is this nature versus nurture sort of thing, right? Like, right. Where is that line? Is there a line? Is it all kind of how we were raised? I don't want you to solve that conundrum, but like from your experience and then learning to maybe see each person as an individual, talk about that.
Yeah, I mean, nature versus nurture, I think it's still something that we still talk about, but I don't think we talk about it as in the extremes as we used to, or in the dichotomy that we used to. We see that, or I see that much more on a spectrum, right? So there's things that are constantly being influenced by nature versus nurture, and for the most part we talk a lot nowadays about predispositions. So our nature can predispose us to have certain reactions that if we have the opportunity or to have an experience, which is the nurture part, right? What happens around us or to us. If we have a predisposition to react a certain way, then we might have a certain type of experience. So it's both nature and nurture kind of happening simultaneously. Sure. And, my genes, my genetics, my things that I've, received through hereditary, then I may be more predisposed to react a certain way emotionally or whatnot. So yeah, I think when it comes to like seeing people as others, then yeah, we may still have some nature versus nurture, but I think the relationship is probably a little bit more on the nurture side. I think we are influenced by how we see people treat other people.
Yeah.
And if we've only seen a very limited type of interaction, then we only have experience and the ability to transpose or to learn that behavior and apply it to a different setting. And as we have more diverse experiences in watching and seeing how different people react and interact, then we have more to draw from when we're in a similar but different situation.
Yeah, I totally agree. My natural inclination is to kind of take this path, and where does it lead to, or is it coming from a path of religion at all for me? Because I know my experience in growing up in Orem, like religion, growing up Mormon, was a very like integral part of me, my perspective on relationship, other people, how to treat other people, who I spent my time with, friends, all of that sort of stuff was very influenced. How about for you?
Yeah, equally. I mean, I think that's part of the culture, right? Whether you were whatever level of activity in the LDS church or familiarity with it, it's in the area we grew up in, it was part of the culture. So I have friends now that grew up in Utah Valley, weren't LDS, but they know the LDS culture. They understand it. They're able to, see me and I see them as, and we can relate in that way, even though we have a slightly different experience. Maybe not even slightly, significant different experience in our relation to the church. But so yeah, growing up in the area, I think did obviously influence my culture, how I grew up, how I saw people interact, how I didn't see people interact. Yeah. There was another thought I had, but it'll come back.
Yeah. And to the extent, like, where, like, you look back on it now and say, I really like how this shaped how I interact with people, or I haven't thought too much about that, or, I don't know, just some general thoughts about maybe looking back about how that shaped you and how you interact or react with people.
Yeah, without getting too into the actual religious part of it, I think in general, go back to what we were just talking about in terms of how we see people, how we learned to how we saw people interact, how we learned to see people interact, and then how we transpose that to our interactions. I think it's influenced by let's call it ethics or morals or values that we have. So let's say kindness, right? So if I'm going to see somebody who's different than me or other, as we were talking about earlier, with kindness, then I need to have to some degree witnessed what that looks like. It's a very arbitrary concept and emotion. It's like, well, how do I show that? How do I interact with somebody? How do I receive kindness? How should I give kindness? And so I think culture, religion, morals, ethics, guidelines, any system that allows us to understand how to appropriately interact with people is good. And so for some people, let's just say religion, or even just a culture that values kindness, service, I think is valuable for anyone in that culture. Now, there's other parts of how we see people behave and interact and react that may not align with those values. But in general, for us to develop and for children to develop, we have to have some sort of compass, guideline, system, to teach us what's appropriate, what's not. And I think a culture or a religion or a system that values being neighborly and serving people and being kind and kind of the Christian values that are inherent in the culture that we grew up in the community we grew up in, I think is valuable.
Yeah.
Not everyone does that all the time, every time.
Yeah,
right?
of
So
course.
you witness how that doesn't play out, but more often than not, you pick up on when it does happen, and those are the things that we can repeat. And those are the things my kids see and are able to repeat.
Yeah, which makes total sense, and I would agree that those are great ways for you to learn, or for a kid to learn about how those interactions work, and then making them work in their own lives. I think to a certain level, like any religion is sort of like this playbook that's already been written. Like if we follow this playbook to a certain level, all is good sort of thing, and that includes how we interact with each other. Do you think that there's room for that playbook to be expanded as time goes on, as you do work as a psychologist, or whatever field you were in? Is there room for expansion in this playbook?
Let me make sure I understand your question. So the guidelines, the values that are inherent in a culture, let's just say in the LDS culture in this area, or in the area that we grew up in, has some certain guidelines or playbook, as you put it.
Uh-huh.
And so should those plays, the plays in that playbook, be enhanced or expanded upon?
Yeah, just as time goes on, we get more insight, we get more information. You, as a professional, can come to those you interact with and say, well, wait a second, what about, what if we looked at doing things this way, or this way, a little bit different than the original playbook said we should?
Sure. Okay.
Yeah.
Okay, so yes, let me put some caveats to that with, again, not getting too far into the religion, I think that there's some core values that don't change, right? That they're truths that don't change, and our understanding of them can expand. Our use of them and our ability to apply them in our lives and in other aspects of our lives, those can always expand, but the truths that are the foundation don't change. However, I would say that those kind of truths, those foundational truths, are there are less of those and more of the ones that we learn and we expand on.
Okay.
So
Makes sense,
while there are both, I think that for the most part, a lot of what we do is learning and expanding and understanding, and as new things influence our lives and our culture, then we have to expand our understanding and our playbook, right?
Sure.
So, even thinking of just when we were kids, we didn't have cell phones, right? We're of that early millennial group where we didn't grow up with cell phones. I got my first cell phone when I was in college, right?
Yeah, me too.
So kids nowadays are having, that's the kind of the quintessential example, but it's a good one. It's a generational difference where now we have to interact and understand how to interact differently, and from a culture, religious, spiritual, moral, ethical, value-based approach. Yes, we have to learn, well, how do we understand these new things into our value system? So absolutely, we need to expand, as we, going back to an earlier part of this conversation as well, as we understand as others, in a sense, as we learn more about how other people are and their experiences, absolutely, we have to expand and understand that as well. And that, I think that's just ongoing and always will be. We will constantly be learning more about each other and how how we grew up, and as we have different experiences and generational differences, we have to expand how we interact with each other and understand each other.
Yeah, I think that's a very important insight for probably yourself and everybody else, is that we should always look at it as expanding, growing. What can we learn from this situation? How does it apply to my current situation, my frame, my perspective, and go from there. Right. I will say, we are recording on library equipment, and the computer just went to sleep. So I think maybe just pause for a second and see if I can get them to unlock it real quick. Okay. Hold on, folks. We might edit this out. We might not. Hold on. Log in. It's never done that before.
Let me try that again. Okay.
Perfect, thank you.
No problem.
Gotta shake that mouse every few minutes.
Yeah, I'm gonna have to touch the mouse every once in a while. Good news, it's still recording. 21 minutes in.
Sounds good.
So yeah, kind of the last thought that just before we were interrupted by the computer going to sleep was this idea that, yeah, of course, we always need to kind of grow, expand, learn from whatever's happening in the world and take it with us. I think this kind of leads me to another area where I'm very curious about kind of your own personal path, is because, knowing you since we were in 5th grade, I've always known you to be a very driven person, always to do very well in school and high achievement in all other areas of life. But I didn't know that this would necessarily lead you down the path of being an entrepreneur, which is where you are now.
Yeah.
So maybe talk about that path. I don't know, was there any insights early in your age to this is kind of what I want to do, or you just kind of arrived there one day because of opportunity and here we are?
Yeah, no, it's a good question, and I ask myself that regularly over the last couple of years since kind of taking the entrepreneurial plunge. There's a couple ways to answer that. I would say at the high level, no, it wasn't necessarily my idea to be entrepreneurial. From the beginning, I went into a career that was, very stable, so to speak, aligned with higher education that was like a safety net, so to speak, and somewhat of a, at least early on going into it, deciding to become a psychologist was it was somewhat prescribed in the sense okay, I go to this schooling and I pass these tests and I get this license and certification to do these things. There was not a lot of unknown.
Yeah.
And so there was safety and stability with that, right?
Yeah, for sure.
Early on, I was really young comparatively when I got into my doctorate program. So I got through undergrad pretty quickly. We both took a lot of concurrent enrollment in high school, so by the time I graduated, I only had 3 classes for associates. Went on my mission, came back and kind of accelerated through my junior and senior year. So I really only had 2 years of formal college. So I'm 20, let's say 21, 22, I was 22, skipping my master's degree and going straight into a doctorate program in a competitive program where they only accepted 7 to 9 people a year.
Right.
And so at that time I had gotten married, wanting to start a family, and my biggest value at the time was stability for my my current, spouse and my future family. And so that played a lot into my early career choices. I actually got home from my LDS mission wanting to be a geologist. You and I took quite a few environmental science and geology courses. We traveled to Costa Rica together when we were 16 to study, volcanoes. And that's what I wanted to be, and got back and realized, there was somewhat some instability in that. I was going to have to move around a lot, and I had some other influences that drove me a little bit more towards psychology. We could go down that path if we wanted to, but of how I got into it. But once I said, hey, this is an option, and I'm going to try to choose between these two sciences, the one was more stability. Fast forward, grad school, graduate, and I'm stable. I've got my jobs. I'm going through, and I get to a point in my career where I was like, okay, things are stable, things are good, and I could stay here, right here, with some inflation year over year. But like I accelerated, moved up the ladder. I was in a C-suite position, overseeing. I was in a pretty sweet gig, and I was happy, stable, making more money than I ever thought I would, to be honest. Yeah. Not astronomical, but just doing well. And I thought, okay, I could just stay there. And really what drove the entrepreneurial plunge was I had spent a lot of my career as a psychologist helping people who were right in front of me, one person at a time, one family at a time. And I felt a lot of value in that. I felt a lot of fulfillment in that. But as I kind of got to the point in my career where I kind of looked up a little bit more and kind of looked at the industry as a whole beyond the individual or the family that was sitting right across from me, and realized that there were a lot of people suffering out there that didn't end up across me, across from me, or across from somebody like me. And so I kind of had this existential moment, and it was less of a moment, more of kind of a long, expansion of my awareness, but that I could continue to treat people who were right in front of me one at a time, and I would do my part. But it still wouldn't solve the bigger problem. And so at some point, if I had the opportunity to make more of a macro influence than the micro influence, albeit that was also fulfilling and valuable, and families need somebody to sit across from to work through things. But if I wanted to make an impact on an industry to change how we approached behavioral health and mental health, I was going to have to do something more than be a therapist. Sure. And so I started kind of intentionally finding opportunities to move my career in those ways. Another longer story we could get into if we wanted, but came across some technologists who wanted to similarly use technology to change how we delivered mental health and behavioral health care. And so they said, well, given your experience, let's consult. And so I said, okay. I had a private practice. I was doing a bunch of consulting anyways, but not necessarily in technology companies. And so we just started doing consulting, and we did that for about a year. And eventually they said, hey, you should just come over full time. And I was like, oh, no. I like my stability. I like what I can see. It's prescribed. I'm risk averse. I'm not an entrepreneur, but I can definitely help. And they're like, okay, well, it's very valuable. Let's just keep doing that. A couple months later, they said, hey, we really want you to do, So it got to a point where I really realized I had this opportunity that I had been working for to make a macro influence. But in order to actually make the splash, I was going to have to take some risks. And I realized that I wasn't going to do that, being like, oh, I'll make this macro influence, but just by staying safely ashore, right? Yeah. But if I was really going to change dynamically how we approach mental and behavioral health, I was going to have to put some skin in the game as well. Not financially, but just in my career. Right?
Sure.
I was going to have to leave the safety of my stable gig and go do something that somebody's never done before. Because that's what it's going to take to change how we're doing things. And it took me probably another 6 months.
For sure.
Of kind of going back and forth and talking to a lot of people and trying to get to a place. Luckily, my wife's very, very supportive. She's like, no, you got to do it. Like, look, you can always fall back on just going back to doing your psychologist work, but this is the opportunity. If it fails, it fails. But you've been wanting to make a macro influence, and this is it, but it's gonna be uncomfortable. Nobody's done it before.
Right.
You're gonna have to figure it out, and you're just gonna have to do it. So anyway, that's how I ended up taking the entrepreneurial plunge, kind of leaving traditional psychology practice, joining a technology startup to make a bigger difference in how we deliver and support people going through mental and behavioral health treatment.
Yeah, I really like that. And I want to talk more about this, larger net to support mental health sort of thing. But I kind of want to go back because this area really fascinates me because I've faced this same sort of mental hurdle, the area of risk. Like, I really like the idea of stability too, like knowing what I'm getting, know I'm going to make a certain amount of money and then I have a health insurance and that, or, other parts of life that I just know what to expect. It's nicer, right?
Yeah.
But I've also realized as I've gotten older, and I don't know if it's a process of age or a process of different life experiences, but as I've got older, I'm like, I gotta start taking more risks. Part of it is living life for me, like enjoying life to a certain level, but part of it is like I think if you're gonna have a bigger influence in lots of areas, you got to be more risky. Another word for risk might be vulnerability. It might be whatever it is.
Yeah.
So I don't know. Do you have any insight on like what that was that you were able to make that shift? Obviously, you mentioned it took you a period of time, but like what other factors? Or was it finally like, okay, I'm finally able to wrap my mind around like, let's just go for this?
Yeah. A few things come to mind. I think I'll repeat what I said before, was just like that insight of just like, okay, it's gonna take somebody being bold to make that level of difference.
So like a larger goal or larger.
Yeah. This isn't prescribed. There isn't a playbook. There isn't a guideline. This just hasn't been done before, and it just somebody's just gonna have to do it. There was a portion of my career where it was like, oh yeah, there's people who specialize in doing those things. There's people who specialize in doing things that haven't been done before. And part of the realization was like, no, there's not. There's just people just being bold, just figuring it out. Like I thought there was some special breed of people or this degree that I didn't know existed in grad school. I mean, yes, you can major in entrepreneurship, you can major in, business administration, but that doesn't necessarily mean that you're going to make bold decisions with that and make, and disrupt industries. And so I really realized that there wasn't some sort of special training. It's just somebody who's passionate about solving a problem, and that's the person. So I realized that I wasn't not that person.
Right. Yeah. I like that.
And it was just like, man, yeah, like I'm no more equipped or no less equipped than another person who just had a passionate idea and just went for it.
Right.
So that's that part. Of course, there was some enough stability for me to do it. So I would say that my experience wasn't maybe I don't know if traditional is the right word, but more of the stereotypical entrepreneurial plunge where it's like, okay, we're just going to quit our jobs, live off of loans, live off of the nest egg, live off of savings, start in the garage. Like that wasn't it for me, and that's actually probably one of the reasons why I was able to find myself getting to the point to take the risk was, my partners are serial entrepreneurs, had taken those risks. So by the time I came into the picture, they had, an amount of money to invest, had some stability around them that, that allowed me to have some stability. So I didn't have to not take a salary or not have in health insurance. So just from day one, from quitting my job and starting the business, I had a salary, I had health insurance, and I had some level of stability around me because people had been successful before, and I knew that could go a long way. So I say risk, but I'd say there's people out there who are taking much more risk to try to make a difference than I had. It was less of a risky thing to do for me, and I think that's why I was able to do it. And then I would say the final thought on that was, well, I think I lost it. Maybe something to the effect of, I had enough support around me that was able just to, kind of that idea of what's the worst that could happen, and barring extremes, right? Yeah. That I'd go, I'd learn, and it could not go well, but I would have learned, and I could come back to doing something, or take that experience and move on. And luckily it's gone well, and things are good, and I still have those things, still learning, still growing, and wanting to apply those things to other areas.
Yeah, the game of worst case scenario is actually very helpful for me. I don't know if other people play it, but I play it a lot now, and it really helps me to really understand, the depth or breadth of a risk or a situation in life. If I really get down to it, worst case scenario, I was that's actually not that bad. And those worst case scenarios are very, very low percentage of those things actually happening. So some bad things might happen. You might have to go back and work a menial job for a period of time or whatever. Right. But is it worth the risk? Yeah, most of the time it definitely is.
Yeah, definitely. If from that approach of, I wouldn't have quit my job and taken the risk for kind of a lateral movement of just I'll just do more of the same in a different area. Uh-huh. It's there's a big enough opportunity to make a big enough change that it's worth the risk. And then I did remember this last thought, which was, I had been valuing stability for so long, and I think probably to your point earlier, it's just you didn't know if it comes with age or life experience. You get to this point where you're, less risk averse, and I think part of that was that life experience. I realized nothing is stable. Mm-hmm. I had this vision of that's stability. And I think, this was pre-pandemic, but even this last 18 months has taught us that nothing's really stable. So I think I just matured and realized, and I looked around me, that the stability that I was seeking for, while probably more stable than other things, isn't necessarily inherently stable, right? And so it was it's just less likely to deteriorate in a financial crisis, right? Construction or something. But there's a few things that are a little bit more stable: education, healthcare. Those things continue even through recessions. But even then, it's not the same level of stability and security that I was attaching to it. Yeah. So I just kind of realized, well, that idea of stability is somewhat of an arbitrary threshold anyway.
For sure.
And so might as well take a risk.
After all, going back to the geology thing, we are on a spinning rock in outer space, like that stability, then interesting, right? But
right. And
it's all about your perspective.
Right. I think my worldview expanded, and so what was once risky, because my frame of reference was so small, and that viewers can't see my hands, but like my frame of reference is this box, and there's this line up at the high top of it. That's where risk existed. But as my box or my window and my view of the world expanded, that line never changed.
Right.
But what I could see above it is now exponentially larger. And so now I look at it in the bigger picture. It's like, actually, that's not as much risk as it used to be, even though it itself hadn't moved.
Right.
But it, in comparison to the larger scheme, had changed. So I realized that there just wasn't as much that I was risking.
Yeah. And, going back to kind of telling your experience about living other places, probably your world of view expanded because of those opportunities as well. So putting some of that in perspective now, given time away from home and different scenarios, a university, a learning experience, a religious experience, those sort of things all expand that ability to take on some risk, probably.
Absolutely,
yeah. So going back to this bigger problem you're solving, we kind of put it as behavior health, mental health. Any more specific? I mean, mental health is kind of like just talking about health,
Yeah.
Health is a everyday thing. Mental health is probably an everyday thing. So talk to about like what problem you're looking to solve.
Yeah, I mean, when I started thinking about this micro problem versus macro problem, or this what type of influence is needed. So in my training as a psychologist, I'm trained and certified and licensed to do very specific things that not a lot of people can do in comparison. So, I ended up having, a really long wait list of people who needed to come see me for my specific skill set. And during that evaluation was going to be used for the next 1 to 3 years to drive treatment for that person. And I mean, to boil it down, what I really realized is I actually don't know a lot about these people. Like I'm at the top of the food chain when it comes to who do you go to figure out what's going on, right? And even me as a psychologist doing psychological and neuropsychological evaluations to determine diagnostics, etiology, and treatment recommendations and prognosis. I only had the information that was directly in front of me through traditional assessments, through interviews with the individual or with family members of the individual, but still just a snapshot of what was going on. And I really realized that as a whole, we actually have very little insight into how people are doing when they're not directly in front of us, when they're not in my office in a session, or when they're not in my facility in treatment. Once they leave, they're kind of on their own. Yeah. And I actually have very, very little insight into what they're doing. So think about like a psychiatrist who prescribes a medication and then the person leaves. And we kind of just cross our fingers and say, good luck, let me know if you have a side effect.
Yeah, and it's true.
And and then when the person has a side effect, maybe they're aware of it, maybe they're not. Maybe they get some help, maybe they call back. And if they do, it's likely that I'll have a wait list or the psychiatrist will have a wait list. They may end up just in an ER because they can't wait 3 weeks till the next appointment. And let's say even they do get an appointment, they'll come back in and okay, tell me a little bit about what's going on. we know people suck at self-reporting, right? I can't remember, especially when I'm dealing with, a crisis or mental health issues. I'm trying to get through today. I can't remember last week.
Right.
I can't remember the week before. And, when I was doing therapy, I would spend the first 20 to 40% of my session just trying to get a download. So, Peter, how have you been since I last saw you? Tell me what's been going on. And you would say, it's been okay. And I'd say, what does okay mean? And we'd actually just have no data.
Right.
Let me rephrase that. We have very limited data to drive our treatment decisions when it comes to mental health. So you compare it to, let's say, high blood pressure. So people can be monitored for that. So I put a Bluetooth enabled or Wi-Fi enabled blood pressure cuff, and I know your blood pressure, or somebody with diabetes, you have a glucometer. Like, I know I have these data points multiple times a day. Cardiac, right? You have a pacemaker. Like, I have data about how you're doing so that it can drive, the doctor can make decisions off of that. We don't have that for mental health. We don't have that for behavioral health. We have very limited data and very subjective data,
right,
and drive decisions. And so I kind of had this aha moment of like, no wonder our kind of demand is high, capacity to meet that demand is low, our quote unquote success rates or our ability to track are kind of like all over the place. It's even that's just hard to track. And so there's got to be a better way to have better data-driven treatment decisions. We don't. How do we have that same sort of data that we have for all these other chronic conditions? How can we have that for mental health and behavioral health? And so that's kind of what drove when I met these technologists and had the ability to leverage some technology to do something to that effect. That really intrigued me, where we can have data around how people are doing emotionally when they're not directly in front of a practitioner or a clinician, and that can really move the needle when it comes to data-driven treatment decisions, early detection, progress monitoring. Who's in crisis, who's not, who needs attention now, who's not, right? Like,
right.
Just adding more therapists isn't going to solve a problem.
Sure.
It's going to solve a micro problem, right?
Right.
They're going to be able to meet with more people, but it's not going to solve the macro problem.
Right.
And so we need something, somehow, some technology to help us do that.
Yeah. So as I'm trying to understand, and of course you can give us a little bit more insight on where this is going, but as I'm trying to understand this, I'm looking at of course the different levels of health and mental health that go into this. I've seen a therapist. I go to a therapist mostly to kind of blow off some steam and talk about what's going on in my life and to get some insightful feedback so that I can maybe take that feedback and apply it. This sounds like maybe a whole nother level that might be more helpful for those that experience a little bit higher forms of mental health, or I don't talk about that.
Yeah, I would say, look, people, the idea of personalized healthcare is applicable across the board. There was a time where we saw a doctor, we got a prescription or we got a decision and that just happened. But I think nowadays people are expecting more personalized healthcare. We want our doctor, our provider, whoever that is, a dermatologist, a dentist, whatever, to kind of know me.
As it should be, right?
And and to know how I function and barring very specific medical cases, a lot of what happens in across lots of health conditions are, well, how is that different for you, Peter? But if I don't know how you were before, then I can't really tell a difference of how you are now. Nor could I make a difference in 6 months from now if you made a change, right? I actually have to know much more about you as a person to treat you appropriately. We just don't have the time, capacity, or business model to have a doctor get to know you at that level of a personal level. Even if I'm treating you for chronic pain, sure, I can make that pain go away with some drugs, but if that doesn't allow you to improve your quality of life and all the other stuff that makes every patient a person, we don't track those things. We track vital signs, only the minimally necessary to make a treatment decision. But there's so much more about our patients and about our clients that make them a person that influence their overall health outcomes. Yeah. So we need to know more about their emotions. We need to know more about their movement, their language, how they communicate, how they learn, how they make change. Like, we have to know all of those things in order to truly deliver personalized healthcare. There's just no way to really get to know that person unless we have this, unless we assign a nurse to just walk around with you all the time, right? Which happens in very unique cases, but that's not scalable. So technology can be a proxy for that. How can we understand more about how somebody thinks, how somebody reacts, interacts, what their emotions are, what's their normal, when are they deviating from that normal, when are they up, when are they down, when are they sideways? That takes getting to know a person, and technology can help us do that.
So are we kind of speaking to some sort of cross between something wearable and something that the patient can report, like on their phone, like a reminder pops up to like record how you're feeling right now, or something more specific?
So for a long time, especially in like, let's just take pain, for example. Rate your pain on a scale of 1 to 10, right? And that's a data point.
Right.
And so if you rated it as a 10, I did some sort of intervention, you rated it an 8, then things have improved. I did something more and you got a 6, and if the goal is to get you to a 3, great. Right. So at the very simple level, yes, having more clinical data points, like a 1 to 10 of just like, well, how are you doing? Let's translate that to like somebody dealing with depressive symptoms. Tell me on a scale of 1 to 10 how you're doing. Better, worse, or about the same, right? And so if I can have those data points over days, weeks, months, then all of a sudden I can create this storyline. We've been doing that in traditional like survey methods for a while, but it's very cumbersome and not super clinically sophisticated. Yeah. So then we got to doing these things for like mood journals. Okay, well, just record your mood. Super subjective, very inaccurate, and self-report, right? Like that is only as good as how insightful that person is. So what we've been trying to build is a way to make that subjective more objective. Right. So we're talking about how can we use technology, like artificial intelligence, for example. How can we extract emotions from kind of a mood journal, so to speak, right? If somebody were to record themselves on audio or visual, can we take facial expressions? Can we take tonality? Can we take inflection? Can we take the words that they're using and how they're using them and get an idea of how they're doing? Right. And so that's what we've been working on, drawing off of, previous work that other people have done. But I think we've built some things that are different and unique, and kind of pioneering this idea of, yes, we can make that subjective emotional experience more objective. And once we can do that, then we can start gathering data points that are that can be used for data-driven decision making.
Yeah, that sounds very interesting. Maybe I could be the test subject, because I think the AI would be like, he's monotone. His affect does not change. He mumbles a lot. We don't know what the hell is going on with this guy.
Yeah, I mean, there's a little bit of like, what we're working towards and things that we want to build over time. And I think, that's very exciting. So we're working on some research projects right now where, look, if we can, let's say Sally was diagnosed with bipolar disorder, and bipolar disorder is notorious kind of for ups and downs and kind of ins and outs of hospitalization, kind of this revolving door. But we actually really don't know how Sally does when she's out of the hospital, because we're not walking around with her.
Right.
So if we can kind of track a little bit and monitor Sally a little bit, yes, with some wearables, or even just through what we specialize in is video responses. So instead of just self-report on a survey or a multiple choice or a mood journal, they actually record themselves on video answering certain prompts, and then we have an AI layer on top of that extracts information out of the video, such as the emotions they might be feeling, their tonality, the word choice, things that, as you're a clinician as well, things that you and I, when we're sitting in front of people, we're taught, well, what do we look for and what do we listen for to understand how to help somebody and what they might be struggling with.
Right.
And so what we've done is just take those protocols, take that research, take that and teach some computer analytics to look for and listen for those same things. So going back to Sally, so if we monitor Sally, and let's just say she's checking in a couple times a week or once a week, we start to learn what Sally normally looks like, sounds like, talks like. And then let's say she goes into a depressive or a manic episode associated with bipolar. So now we know what Sally looks like, sounds like, and talks like, kind of quote unquote normally. We know what she looks like, sounds like, talks like when she's in a manic or depressive episode. And if we know that, we also know the in between. We know what Sally looks like, sounds like, and talks like right before a manic episode and right before a depressive episode. So now we're really getting predictive. Now we're really getting preventative. So we can actually start to learn what it's like right before those things happen. But that takes some time to gather the data out of and really understand Sally.
Right.
And it takes technology to do that. And we've seen that play out. So we're working on a research study to do that with the university to track a set of patients diagnosed with bipolar over a period of time and start to learn those patterns at an individual level as well as a population level.
Right.
And we've seen that play out with our current customers. We had a patient, a client who was checking in on our platform, and he was dealing with some drug addiction, and so he had been in rehab. The treatment center had, after he left the treatment center, had him check in on our platform once a week for a couple of months after that, so they can kind of just keep track of it. And during one of the video check-ins, our AI picked up on he was using more absolutist language.
Okay.
Absolutist language is basically just the AI kind of going through what he said in the video, transcribing it and kind of scrubbing through, looking for words like always and never. And he had increased in his amount, his total percent usage of those type of words over the last couple of weeks. And so his therapist got that information from the platform and got an alert from our platform saying, hey, so-and-so's using more language like this than he normally does. So he actually brought it up with the client, and they actually had this insight. It was just like, oh man, I don't know if we would have picked up on that, right? It's not like we sit there really trying to understand, like, okay, how many always or nevers did he use? But once they picked up on, they realized that's one of the things he starts to do when he starts to decompensate, right?
Yeah.
He starts to think in extremes. He starts to categorize in black and white. He starts to think all or nothing, and that usually has led him to drug abuse. And so that we were able to catch that early on and be like, okay, hey, not everything's black and white. We intervened, and they were able to kind of keep him on a good track. That's just a small example, not like, that picking up on absolutist language saved his life or by any means, but it was an insight that we wouldn't have likely picked up on.
Right.
And we're able to, at least to some degree, be aware that, hey, you're starting to head down a path.
Sure.
Or this is a yellow flag of warning signal if you're heading down this path, so let's do it. And man, if we can do that at that level, if we can get more sophisticated on the type of metrics we can track, what we can learn about people, and what we can start to understand about the development and pattern of these types of chronic conditions, then we can really start to make a big difference on early intervention and prevention rather than just remedial reaction.
Yeah.
Which is mostly what we do nowadays.
Which I love. I love the idea of prevention. A lot of the work that I do is prevention related, and I think it's super important, and I think it's something that we as a society ignore a lot. It's less about prevention and more about intervention. You know, let's wait till there's a big issue to intervene rather than try to prevent. A couple of things you said, though, I'll be honest, kind of scare the shit out of me because like you keep using the word we. You know, we can look at the data, and I'm assuming that when you say we, you're actually talking about a clinician, but also the technology is the part of the we. So it's almost like this weird sort of team where you have AI, the patient, and a clinician working together. I get it. I get, like, that's why we're going that way, because technology can be very helpful, but at the same time, it is, like, kind of scares the shit out of me. So, like, talk me off this ledge. Like, talk to me about how this is not going to go wrong, and, you know, it's all going to be good that we're using technology to help us out.
Well, look, technology innovation always has its, I think we've seen through all medical innovation, there's ways that it can be used for good and ways that it can be for bad. So I don't think now that we're just talking about technology, we're talking about software, we're talking about computers, we're talking about AI, that's any different than, you know, the advent of new medications or, you know, the X-ray or something, that were new at the time as well. So yes, there's AI in healthcare is gaining traction. It's gaining a lot of attention, gaining a lot of value, and making a big difference in a lot of areas of healthcare. So there's new guidelines coming out, and of course, people can be ethical and not ethical. I think the things we have to think about are, can we be accurate? Can we be ethical? Can these types of things be used in a way that is helpful for people versus damaging to people? And part of the thing that I would say in comparison is and I can say this as a clinician, some people may not like it, but we as clinicians aren't as good as we think we are anyway.
I would agree.
About, we do the best that we can, and when we help, but when it comes to really moving the needle on very clinically sophisticated metrics in mental health and behavioral health, we're not super good at processing a lot of very specific emotional and personal metrics at any given time, right? Like I could probably sit here and have a therapy session with somebody, and I'm focusing on 3 to 5 kind of mental health vital signs that I'm trying to, that I've picked, that I'm trying to pay attention. I can't do 100. I can't pay attention to how fast they're talking unless it's in extreme buckets.
Right.
But a computer can help us do that. So in a sense, technology can help empower clinicians to be better, not replace clinicians. And there's been in the past kind of this trauma, for the lack of a better word, not clinically, but there's been this experience by people having this kind of black box understanding, meaning, hey, we're going to gather some data about you, and we're going to spit out some understanding, and you can't know how we came to that conclusion. And that's the scary part. And we as a company and we as kind of healthcare providers want to open up that black box.
Okay.
Right. So our AI is not black box AI. So we're very, even on our platform, if you go over and hover over some of our computer analytics, it'll tell you how we derived that.
Okay.
So let's just say rate of speech, for example. Not very AI-ish. It's just how many words did you say in a minute. Right. So a pretty objective thing to do. Now, if you speak really, really, really fast, more than normal, does that mean you are manic? Does that mean you're anxious? I don't know. The computer doesn't know either. It just means you're talking faster than normal.
Right.
So there has to be a clinician involved to say, they won the lottery, so they're excited, or no, this is a so it's information that we wouldn't have had otherwise for clinicians to make better informed decisions. Now, in the future, yes, I do think we will get more sophisticated. So we're right now just finishing up. I'm speaking at a conference later this week and presenting our preliminary results on. We can now start to accurately predict severity of depression and anxiety based off of 30 to 60 second videos.
Oh, wow.
And, they don't have to go sit in front of a clinician. They don't have to go necessarily take a big, long depression screening survey or anything. This is just off of some video, we can start to detect some of that stuff. Now, does that mean they don't have to meet with the clinician anymore? No. It just means that when you check in a couple times a week or once a week, in between the times where you do see a clinician, now we have a lot of information about how you're doing. And that's available to a lot more people, right?
Yeah.
Through software, through text them a link, click this link, video record yourself, answering these prompts, and we can get a better idea.
Yeah.
Not a perfect idea.
Right.
But a better idea of what might be going on.
Yeah.
So I do think we're getting to a place in the future will be more diagnostic, more predictive. Right now we're not there. Right now we're gathering sophisticated information that we otherwise wouldn't have had to empower clinicians to make better decisions, and information that we don't have the capacity to get right now. We don't have the time, money, and resources to do that level of personalized care if I have to do it myself manually. But if somebody has a smartphone, a computer, can check in regularly, give us a little bit of some clinical data points, we can start to really understand the narrative of this person at a personal level. Yeah,
which is incredible, and I think sounds like going to be very useful and hopefully solve a lot of problems. So, like, maybe to put this in perspective, and this is possibly just for myself, like Google and Facebook don't want to open that black box and tell you how they're arriving to how they send you ads or what data they're collecting on you in order for them to make you money. But for you guys, you do want to open that up and let the consumer know all these metrics, everything that's going into making decisions or suggestions, and the clinician can walk you through that and say, like, look, we've collected this and this, and this can be an insight for you to know this about yourself or whatever it might be.
Yeah, absolutely. People can gain more insight about themselves. There's this concept called feedback-informed treatment, which states that the more somebody has insight into their own progress or lack thereof, the quicker they can make meaningful course corrections, and they get better quicker. Yeah. Because they have more feedback, right? It's like this idea of, like, how do I know if I'm on the right track if I have no understanding of where I'm at? And yes, that can come through clinician feedback, but often these kind of like more micro feedbacks, right? There's more information I have about myself and more objective information I have about myself, then more data I have to improve myself. And then, of course, for the therapist as well, right? The sad reality is we'll see a patient. I may think about them for a couple minutes afterwards, and then I may think about them a little bit before my next interaction with them. But in between, I'm off thinking about other people and people right in front of me as well. So, so we kind of have to have that information about them to have those insights at a personal level, and as well as the clinician, right?
Yeah.
They need just as much that information to make decisions.
So do you anticipate, or have you thought about whether, giving the patient or the client themselves this much information and this much coaching at this sort of level, if eventually they'll get to a point where they can coach themselves, where they're so insightful about themselves that they don't need computer-based learning, they don't need AI, they don't need a clinician. They're just like, okay, now I've learned my rhythms, like I can see it for myself, I can course correct all by myself.
Will we get to the point where we have enough information that people can kind of course correct themselves? I don't know.
Safe answer.
I don't know. I will say, if that were the case, then great. Right? But the reality is, it's probably not, right? That humans are a little bit too complex, But maybe for certain things, right? If somebody has a mild case of this or a mild case of that, and they're not in severe crisis, but they do need a little bit of help,
right?
But they have to go fight for in the same weight line to go talk to a therapist that somebody who's actively suicidal is in. We have just this broad spectrum of people experiencing mental health and healthcare in general at so many different levels in the same line.
Yeah.
And so we've got to do a better job at kind of triaging. And those people who just need a little bit of help for a short amount of time, what can we do to give them the resources and insight to do that? And then the people who are in more severe cases who need some more help, how can we do that? How can we surface those people at the right time,
right,
to intervene, right? I was talking to a clinic the other day, and they'll, out of a week, they'll spend about 20% of their time wasted because of no-shows. Okay. Another 20 to 30% of their time with people just checking in. They're actually doing okay, but I'm just here for my checkup, just checking in, just keep on course. So that's almost 50% of their time, while people are just busting at the seams in ERs. While people are on my wait list who are in crisis, actively suicidal, but I can't get them in for an opening. And I'm saying me, but I'm saying the royal we as healthcare professionals.
Sure.
Because I'm seeing other people first.
Yeah.
And they deserve attention as well. And there's a difference,
right?
Yeah. Who needs my expertise and my attention now? And so we've got to do a better job at understanding where people are more frequently, so we can intervene at the right time with the right people.
Yeah.
So back to your question, yes, I think that as we do that, there's the possibility that yes, there's new apps, new technology where you can kind of have these kind of self-guided. It's like the new version of a self-help book.
Yeah,
we've always had self-help books, but
it's
kind of, instead of in a book, it's on an app or it's on a platform where it's you put in this information about yourself. What are your goals? What are you trying to work on?
And more interactive.
Yeah, and it brings in research and modalities that we know will work, cognitive behavioral therapy approaches, and we kind of and it kind of guides you through that. Look, to be honest, there's probably not going to be any shortage of issues here.
Right.
So I don't think that by having technology help people who are in a place that just need a little bit of nudge and help, and that maybe not solves the problem, but addresses some of that for them, and they don't end up in my office, great. In the end, we're not trying to replace therapists. I think there will always be a place for clinical human judgment. But like that's a good step in the right direction, because there's always that gives us more time to do what we do best, is treating people, or what we do best, and what's needed most is to treat people.
Right.
I mean, if you think about it, like, people don't talk about suicide in this way, but people are killing themselves. Like, just let that kind of translate for a second. We have people who are literally killing themselves, and we can't intervene, and we don't have the capacity to intervene, and and it's increasing, it's happening more. Of course, trends go up and down, but it is prevalent in all of our communities.
Sure.
And we have to find a better way to identify and help and support and monitor these people who are suffering. And if saying, hey, here you're experiencing this mild condition, here's some support tools, because we have to focus on people who are killing themselves, or who are suffering in their families, and who are unstable, can't hold jobs, can't hold relationships. Like, these are serious, fundamental societal issues that we need to address, and we don't have the time or the capacity to do it. And so technology can help scale those types of interactions and interventions to do it. It's a long way of saying yes. I think people can get to a point where they can have some self-guided treatment on kind of the more mild end of things, kind of self-help, self-improvement, overall health, wellness,
right.
That type of level.
Yeah.
But the more sophisticated, complicated things are a little bit trickier, right?
Yeah, for sure.
The cost of our capacity to treat all of these people is low, and the cost of not doing it is high.
Right.
People die.
Yeah.
Right? And we say that in the medical field a lot, of people die of cancer, people die of these other things. And in a very similar way, people are dying because we haven't figured it out yet.
Right.
We haven't figured out what patterns to look for, what things to identify, how do they get help in when they need it.
Yeah.
And we just have not figured it out yet.
I suppose part of figuring this all out is getting buy-in or participation, right? Getting people to participate on a platform. I mean, obviously there's going to be a certain percentage of people that recognize they have a mental health challenge, issue, something they want to address, and they'll come and get help. In order to prevent larger things, it would obviously be better if people participated that just already identified that, oh, I'm great, everything's cool.
Yeah.
Well, how are you gonna, any ideas on that barrier or that hurdle of like participation? Because obviously I think you could probably look at the COVID situation right now, and participation and a certain level of health participation is kind of very divided right now.
Right. So yeah, thought about this. It is something we think a lot about. I'll try to answer that in a couple different ways. One, you are right. There's a certain amount of people that no matter what you do, they're just not going to participate. Mm-hmm. And that's not just mental health or behavioral health care. They're not going to brush their teeth. They're not going to go see their, they're not going to go for their annual checkups. They're not going to get their, they're just not going to participate in healthcare. Those people, that's just across the board. There are another set of people who, understand that I fell on my bike, my wrist hurts. I need an X-ray in order to know if that is broken. So they're more likely to participate in an X-ray to determine if my wrist is broken. I think at some point we'll get to a point where people understand mental health, behavioral health, overall wellness, even just the comorbidity of these things with general medical conditions, that there's a certain degree of like quote unquote x-rays insight that we have to really elevate the type of treatment we get. We've actually just had a pretty low bar, and we're just kind of used to it as a society, as a healthcare system. And so we haven't really realized, it's like, oh, I can take an emotional x-ray or an emotional blood draw and find a little bit about what's going on. And as you know, as we address the stigma with mental health, as that becomes more accepted, as people understand that our mental wellness actually drives and is underlying all of our health conditions, even if you're being seen for medical reasons, that our quality of life, our emotions, all play a part, and it's all intertwined, right? We're realizing that over the last couple decades, and especially the last couple of years, that it's all intertwined. Health is health, and so I think people get to a point where they understand that these are the types of things that are part of the healthcare process for my doctor to understand more about me in order to treat me. And those people who already have that insight, we're seeing great participation, right? There's people who are like, yes, I want to get better quicker. Like, I don't like being in this spot. And so whatever you need, doc, whatever information you need to help me is I'll give to you, right? We're used to going to a lobby and getting the clipboard, and filling a bunch of stuff out.
iPad now.
iPad, or they send you a link first. We're used to giving some of that information, but we're just used to giving static information. How much have you had a surgery? What medications are you on? When was the last time you were seen? Does anything hurt? Like, we're just used to giving static information, but we're used to giving information. So that it's a small step to say, start just giving us different information. Right. And I think if people understand that, hey, you get more personalized healthcare by giving us different information, I think we've seen great success so far. And like, I'll give you what you need. And in fact, I have more opportunity to tell you what's going on with me. Because the average, visit with a primary care physician is 9 minutes. It's an hour to hour and a half long process. But you're only with the doc for 9 minutes. And he or she making treatment decisions based on that. So, if I want to give more information so you understand more of what's going on with me, so you can treat me better and I can get better faster. I think generally people want to do that and are willing to do that. I was being a little critical. I would agree that a lot of people are in a place where, like, if all it took was them recording themselves in a 1-minute video or whatever it is, to answer some questions, they would be all about it. I mean, for heaven's sakes, we have people recording TikToks and telling us about all kinds of facets of their life. Surely they can, answer a few questions. There's really no. It's funny when people say, "Oh, well, they're going to record like that's a barrier." It's like, have you seen social media? It's not a barrier whatsoever. Even the older generation who's not used to that we're still seeing a lot of ability and willingness to engage digitally with healthcare providers. I think people do. There's a level of adoption early on that we do see. That's like I mentioned, they're used to giving information. They're willing to give the information. They're even willing to give different information. The method of gathering that information's a little novel, right? Because they're used to recording themselves. but they're not used to giving information via recording. And so we do see some questions around that early on. So we do arm a lot of our customers and hospitals that use our system. Hey, here's how you kind of explain it. Here's how you understand it. You know, we're very open about our privacy and how we use the data. And so we kind of give them some of those frequently asked questions, so to speak. But we really do see once somebody takes a session and checks in on our platform and really realizes that, oh, okay, this isn't like robots taking over. This is just
not so bad.
This is just recording something that I can then submit to my provider, and they have more information about me. And and even nowadays they're used to traditional telehealth where we're live talking, and so they're used to digitally interacting that way. And this is even more convenient, right? That I don't even have to wait to be live with a clinician. Because traditional telehealth is more convenient for the patient because I don't have to drive to the office.
Right.
But it's not any more convenient for the provider.
Right.
It's still the same 15 minutes that I have to take it. It's still as inconvenient for both parties to try to find a time to meet. I only have availability at 2 p.m. That's the only appointment available. And so I have to take time off at work. I got to get somebody to watch the kids. I got to do this. I got to do that. Whether that's in office or via traditional live telehealth, it's still capacity constrained by schedules. Asynchronous telehealth, which is what our platform is kind of preloaded. I know as a clinician what I want to ask, what I need to know. That's why we go to med school. That's why we go to graduate school. Most of our questions are semi-structured. We know the information we need for the most part out of a patient. Not all of it, because we have to interact in the moment as well, but 70-80%, the majority of it, we already know what types of questions we need to ask. So we can preload those, send a link to 100 patients, and say, hey, in the next 48 hours, kind of just answer 3 to 5 questions, some information. And I can wake up, I can get to my office on a Wednesday morning and have check-ins from 100 patients. There's no way I would have been able to do that in 2 days. But now I know exactly how everyone's doing. And let's say, the AI picked up on a few things or there's some responses that are concerning. Now I know who I need to reach out to and focus on.
I think that would really help so much in this triage sort of phase. You talked about making sure that those that need it most get it as soon as possible, and those that maybe just want it to help and improve a certain situation, but it's not an emergency, then they can get that when they need it as well.
And it's not that those people will always stay because there's always going to be people in crisis. So at some point we have to also give them attention as well. But it does allow us to scale our interaction. It solves the problem of I can't be everywhere at once, but I need to be in order to provide better treatment. And so I need to somehow replicate me as a clinician, or you, or whoever it is. And so these are the types of questions I'd ask. Let's get that out to as many people as needed. And now I have more information.
So what about language and culture? Is that we got to get there after we figure out these first steps sort of thing, or is same, just need to have somebody that can interpret language and culture?
Yeah, language and culture is obviously a big part of anyone's personalized healthcare and personal treatment. When it comes to AI, as well, right? So can AI pick up on tonality for a certain culture better than others? Like, that's absolutely something we have to be aware of, and that we are aware of, and that we make sure that we're not using any computer analytics that are biased or discriminatory. Are they perfect? No. Or will we learn over time? Yes. And the funny thing is, when people kind of ask a little bit about that, it's like, well, compare it to a human. We're biased. We're even unintentionally, even subconsciously, we're biased, right? And so it's not that it can be eliminated in a sense, but we might just have a better chance to being objective than our human nature.
Right.
And that we're already introduced into the therapeutic interaction or into the healthcare process. So it's already happening. We're just trying to improve it.
Yeah.
And make it more objective. And the second way I was thinking about that as well is that oftentimes when we're gathering data about somebody, we can compare it to a normative sample, right? Mm-hmm. Like, how do you compare against what we would quote unquote normally see? Are you more or less than what we would expect? And that really requires some understanding of culture and normative samples. At an individual level, though, as we're talking going from this episodic care to like seeing your doc every once in a while or seeing your provider every once in a while, having a limited information and you just have to hurry and download, moving from that episodic care to more continuous care, it's really more about you as the individual. What is different for you? Right. So let's use rate of speech, which we were using earlier. Do we know for the average American, U.S. American, how fast somebody talks on average? Yeah, we know. So, but does somebody talking faster or slower than that average mean something? Probably not, unless it's an extreme.
Small city versus big city.
Right, exactly. Or southern versus northern, right. or just somebody just naturally talks a little bit faster than somebody else, like that.
Right. Yeah.
So to some degree for personalized healthcare, it both matter, but it matters slightly less how you compare to other people, and slightly more how you compare to yourself. Is this more or less for you?
Right.
Right? So if somebody's baseline is talking at 140 words per minute, okay. So if they're talking at 150 the next week, okay, slight increase, but probably not concerning, right? But if somebody's baseline is 100, average American is about 120. They're 100, a jump to 150 might be significant.
Yeah.
So it's really how do we compare you against you? But the only way to know that is to know more about you.
Right.
That's why we're so used to just comparing you against the norm.
Right.
Because we do this one big, huge study 10 years ago, we get a normative sample, and now we compare against you against them.
Right.
But that doesn't actually help me understand you any better.
Yeah. I like that. I think it's so important to, have some sort of group level comparison versus just this is normal for me or not normal for me. Do the ethics of this change at all? Like, the main ethics of mental health is like if you're a harm to yourself or somebody else, then that's when we break this confidentiality and have to share the data about you with somebody else in order to get you the help you need. Are there any changes that you guys have come across or any other implications you've come across with the ethics, all of this? Yeah,
we get the question a lot of like, well, what if somebody says they're suicidal on a video, right? Am I now liable to have known that in the moment, or if they said something, do we as a company have to report that? So, a couple ways to talk about that is at the simplest level, this type of technology is a sophisticated data gathering tool, right? So it's a tool. It's not an intervention. It's not a clinician. It's not making decisions. So it's just a data gathering tool. In the same way that the clipboard or their iPad is gathering information. Right. We're just doing it at a much more sophisticated level, right? Rate of speech, emotion, affect, sentiment, right? Things that you don't pick up on an information sheet on the clipboard or the digital format of that. But at its core, it's still just information to be used. So traditionally, let's say I'm treating somebody who has suicidal ideation, and they leave my office. They weren't in an active enough situation or ideation that I needed to hospitalize them or anything. And they harm themselves outside of my office, right? There's some inherent risk that we take treating people with these type of severe conditions and things that they're struggling with. Mm-hmm. And so by using a technology tool to help gather information, I don't think increases or decreases the liability that we already have. Right?
Yeah.
We already have that liability as clinicians. So you think about like our old voicemails, and you still may hear this sometimes. So, hi, this is Dr. Brett Talbot's confidential voicemail. Please leave me a message. If you are experiencing a crisis or an emergency, please call 911, right? Because, quote unquote, I don't know when I'm going to listen to my voicemails.
Don't leave a crisis on my voicemail. Call 911.
Right. Yeah. And so you put that disclaimer on your voicemail.
Right.
And now you're kind of, there's this understanding of like, this is you're going to record some information for me to get at a later time.
Right.
These type of technology tools at some level are similar, right? We give that same disclaimer. It's the same terms of use that, hey, you're going to give some information, but somebody's not necessarily actively watching it.
Right.
And, it will be analyzed and reviewed later and used to help to know you better and treat you better.
Right.
So again, no more or less liability than we already have. And we put those disclaimers on each, just like on the voicemail, each time somebody checks in on our platform, that disclaimer is there in kind of that instructions page before they begin their session or begin their check-in, and it's kind of throughout all the legalese of everything as well. But so we're taking on the same liability, but the opportunity to improve care is higher, right? So even me, if I had to take on a little bit more risk to make a lot of difference, I still might do that.
Right.
But we're kind of saying, no, you just have the same liability you already have, and the opportunity to understand your patients and clients better is very high, and empowering and powerful. So, we should and could and need to get past some of this, like, I don't want to be responsible. Well, you already are.
Right.
So if you didn't realize that until now, then that's another issue. But you already are, so let's just do better.
Yeah. I suppose, maybe one area could add in another layer is that, if you have something recorded from somebody saying something, and it might be helpful in some sort of investigation. You're now to like this whole thing that Apple got into is like, oh no, unlock this person's phone so we can see what they were saying before they broke this law, so that we can figure that out. You can get yourself in those sort of situations, and I suppose that would be part of the liability that the client would sign or a release. It'd be like, we can share this in certain situations.
Well, so it's hard to talk about. What would happen in this case? So let me respond that in general, which is healthcare interactions are protected through HIPAA, right? And even more so in some other cases. And so whether a clinician wrote down some notes on a notepad or a patient recorded some information on a video, the information is equally protected because it's personal health information, right? So that's protected. And so it would be up to the clinician to determine when that information, whether it's on a piece of paper or on a video recording through a vendor's platform like ours, when those things are to be released or not, right? So again, it's actually not a whole lot different than what we've always been, right? Somebody could subpoena my records if I typed them on my electronic medical record, right? And the information that's being gathered about patients on a platform like ours, protected just just the same. So there's really not a lot of difference in what we're doing now versus what we've been doing before from a liability and from a protected standpoint. It's just different information. But same process, same rules, same protection.
Yeah, that makes sense. So you talked about the platform. The platform is called Videra
Health, yes.
Videra Health. So where are you at in terms of scale and use, like in terms of people, clients, businesses using this, and where is it going?
Yeah, so it's funny because we'll go back to that idea of like stability and entrepreneurial plunge, and I said, well, if I'm not going to do it now, there's no other time that's going to be more stable than now.
No better time than now.
Right. And so that was August 2019. Quit my job, started this business, incorporated it late August. We had been working kind of moonlighting to kind of get beta versions of the platform up and going. So we actually launched our first, we had done an NIH funded grant study prior to this to kind of prove out the technology. So we'd had some live patients on it from a research standpoint, but not from like a commercial standpoint. So we onboarded our first facility, treatment center with live patients, February of 2020.
Okay.
And we onboarded our second clinic with live patients the first week of March 2020. Second week of March, COVID hits the world, particularly in Utah, kind of world stops, right? So all of that context to say we're a young startup. We have a lot of my co-founders, have years and years of entrepreneurial experience, as well as building AI technology and video analytic technology. So we have a background, but as a company, as Videra Health, we were somewhat young, and then all of a sudden the world stopped. And to some degree, like our technology can be very valuable. Like we saw for like a situation like a pandemic. So we saw a massive increase in adoption of telehealth because now we can't see people face to face. At the same time, that black hole still existed, right? We still actually don't know how you're doing or progressing when you're not in front of me, whether it's in my office or on video.
Right.
So there was some opportunity to have that. So we got a lot of big calls early on, but our product wasn't quite there yet, right? Like we had just launched. We just had a few people on. So there was a time in 2020 where, where that idea of stability kind of really came into my mind again. Luckily we've been able to grow through the pandemic, and we're not where we want it to be in terms of overall adoption and growth, but we do about 10,000 sessions a month right now. And adoption and participation and engagement vary. We're in settings such as behavioral hospitals who use us for post-discharge follow-up, kind of automation of what used to be people just calling saying, "Hey, Peter, it's been weeks since you last discharged, just wondering if you're okay." Like we can now automate that. They're checking in more often. We're getting more clinically sophisticated information. We're in outpatient settings, psychiatric offices, addiction and drug abuse clinics, in a variety of settings that way. We're expanding now beyond, core mental health and behavioral health treatment to behavioral health kind of integration. So we're starting to work with OBGYN clinics who are struggling to detect, track, and treat postpartum depression, which is a huge problem. And they're not equipped to do that. A mother is at home, maybe comes into the office 3 times, 4 times, but what's going on in between that, we really have no insight into how mom is doing.
Right.
So now she can check in on her smart device, record a 30-second video, answer a few questions, 3 times a week for those first couple of months after giving birth. And now we really have insight into how mom is doing.
Yeah.
Same with pain clinics. We're people who are trying to treat chronic pain with some medications that can be dangerous and addictive, and so we're in early conversations of how to track and monitor pain patients in between those appointments, and they need to be checking in to make sure they're not misusing or diverting dangerous drugs.
Right.
And if they're not having the effect that they need to, well, let's get them off those drugs earlier before they become addictive. Things that we're just seeing, our mental health and our behavioral health is much more intertwined into our overall health.
Sure.
And finding ways to gather and empower clinicians with better information in a lot of different settings. At our core, we're humans, right? At our core, we're emotional. At our core, there's much more to what makes us than the vital signs that we get at the beginning of a checkup in an office, and that's true across whatever health condition. We're focused on right now on behavioral health and mental health. That's partially my background, as well as probably one of the bigger gaps in the larger healthcare landscape. But eventually, we see it being applicable to lots of different monitoring. The concept right now in healthcare is called remote patient monitoring. We're doing that a lot for specific things like I mentioned, diabetes, high blood pressure, other chronic conditions, heart conditions. We have devices that will monitor very specific metrics for those conditions. And what is the metric and what is the device to track humans, to track us as a person, and we find that the metric is you, right? Yeah. Not a vital sign, not your weight, not your height, not these vital signs, but it's you. It's understanding who you are, how you are, all those things that we talked about earlier. How you sound, look like, talk like. Across your health journey. That's the metric. What's the device? Well, also you, right? Yeah. And right now, what's the best way to capture you? Video and audio, right? Right. It's not your necessarily just your heart rate, right? And then biometrics. We're integrated with the Apple Watch right now, so somebody who has an Apple Watch, in addition to the video and audio that we gather, we can pull information off of the health kit as well. And that, so all of this information that we can start to gather to really understand you. Right. And that's the core metric and the core device of how you as an individual and go through your health journey.
So if I'm catching the vision, 10 years from now, Videra Health is not only helping access with mental health, but maybe just health in general. Maybe it's just a larger platform where people go to check in on all avenues of life and then get, connected to the appropriate professional from there, or would you like to be more specific?
Yeah, well, I mean, there's a lot of ways. Technology, this type of innovative technology can be used a lot of different ways. If we try to do it all at once, we won't do any of it well. So I think there's a pathway. What you kind of highlighted is kind of this idea of a top of the funnel. Like, can we assess need. Right now, you usually have to either self-assess.
Right.
I need this, which generally we're not good at.
Right.
Some people are better than others, but generally we're not good at self-assessing. Or you have to be in front of a professional to assess you.
Right.
Right. And there's capacity constraints there.
Right.
And consistency issues with that, right? So that's why you get people flying from all over countries to see somebody specific because they're good at that type of assessment.
Right.
Well, that sucks, right?
Yeah.
That doesn't create access to good healthcare.
Right.
That creates a bottleneck to specific people who are very good at that, which is great. But we need to make that more accessible, more scalable.
Yeah.
So top of the funnel, can we assess people more broadly? Sure. Like that could work. Could we assess very specific conditions down to postpartum depression and when that onset happens? We could do that as well. Side effects to medications, we could do that, So there's top of the funnel, bottom of the funnel. There's assessment, prevention, intervention, follow-up, right? There's this whole journey of care. And so in reality, it's applicable. The bigger vision to what you were saying is that, understanding somebody at an individual level at any point with any condition is good.
Right. Yeah.
And so over time, we'll just have to get there, kind of one condition at a time and one use case at a time.
Yeah. Makes sense. So, if people wanted to follow you, hear more about Videra, use the product, use the platform, what's that next step?
Yeah, right now we are. It's somewhat of, think about it as kind of prescription based. So you'd be working with a provider that uses us. We don't have like a direct to consumer app right now. So again, keeping the clinician in the loop. So we're not, gathering information, feeding back information to a patient or a person who may or may not know what to do with that information. Right. There's good to that. There's also potentially, bad to that.
Right.
And so we'd like to keep a clinician involved. So right now, for people want involved, ask your provider, whether that's, your OBGYN, your pain doc, your therapist, your clinician, whoever you're working with. If you want them to understand more about how you're doing when they're not with you, and to get better quicker, then just ask them about if they're using Videra Health. You'd like to check in on that, so they have that information. If they're not, then you can reach out directly to us, viderahealth.com. Follow us on all the social media platforms.
Sure. Yeah.
Follow my personal LinkedIn, as well as all of our other platforms. And ultimately, yes, people who want to be a little bit more in the driver's seat of their own health journey want to do things like this, right? And there's some old school clinicians and old school providers who don't want to do things differently. And so I think part of the movement as well is that if we want personalized healthcare, if we want our provider to know more about me, then we also have to demand that. And it's been hard to demand that,
right?
Because it was very easy for providers to say, like, look, I can't, you can pay more and I'll see you more, and then health insurance won't cover it, all these different constraints that it just wasn't possible. And now it is, right? Now it's possible. And so if we want that, if we think we're going to get better quicker because of that, then we also just need to ask for it. And then we'll work with people. We definitely know where we understand a healthcare process and what can be valuable. We also understand that there's areas that we need to learn more about.
Yeah.
And so we're happy to engage with any interested providers or people who want to use something like this, that we can figure a way out to do so.
Yeah, cool. I think one, kind of final thought that I had, just from more of like a personal relationship level, me and you sort of have this way that we deal with mental health, and I'm assuming a little bit here, but I think it's a safe assumption, is that we go outside and use the outside spaces of Utah a lot to help with our mental health, whether that's hiking or biking or skiing or whatever outdoor activity you choose. I think a lot of people, especially here in Utah, might be interested about that connection, about like the connection between maybe improved mental health and getting outside. Do you want to talk about your personal experience with that?
Yeah, so associated with, but previously to starting a technology company, one of my core areas of focus and of research was the use of outdoors, nature, adventure as a treatment modality. And so spent a lot of years of my career involved with that, and we're still and I'm still involved in that as well. So yeah, I mean, there's a lot of research saying we can own and control more of our healthcare journey and our healthcare experience, and it doesn't have to be traditional in-office stuff, right? So let's just take mental health, for example, kind of the quintessential, lay down on a long couch, guy with a sports jacket and a bow tie sitting with a clipboard. We've moved away from that a little bit, but we're still stuck on a couch,
sure, yeah.
in an office,
right?
And I've seen value. The research suggests that there's so much value to kind of taking therapy off the couch,
right,
into the outdoors, and how much value that brings. And I think to tie that kind of into my current endeavors is that we really realize that healthcare and health journeys happen in real life, in real time. Like it's right. Just this idea like, oh, healthcare only happens when you're in an office or in front of a clinician. It's like, that's only at best,
right,
50 minutes a week for somebody who's seeing an individual therapist weekly, right? And that's that's a lot for most people. But the other 24 hours of that day and the 23 hours for that day and the 24 hours of every other day that week, healthcare is still happening in real life.
Right.
And if we don't have insight, if we don't have data, if we don't have a different way of going about that, if we continue to just stick with in-office vital signs only, then we're going to continue just to get the same limited information and limited results that we have.
Yeah.
We have to think alternatively. And we've thought alternatively for a long time, but to this point, it's like we've seen great success by doing the same modality, the same interventions in a different setting. Right? The same therapy you would do sitting across from on a couch. Just do that same thing under a tree.
Right.
Or next to a river, or walking on a trail. And we see exponentially better outcomes by doing that. And same thing with any type of assessment or intervention or data gathering. It's like we have to realize that after our patient leaves our site, they still exist.
Right.
And their struggles and their successes and their emotions and everything still is happening. And I think the wilderness and the outdoor therapy modality and context has really taught us that things are happening outside of the office, and we need greater insight into it. So yeah, still very passionate about treatment modalities that get people outside of a traditional quote unquote four walls. To think about their journey differently and at a different level. and engaging with each other at a more personal, outside of the formal office, engaging with each other differently that way.
So you, Dr. Talbot, you're going to decompress, de-stress, let go of things. What are you doing?
Nowadays that is more limited. But in the same way that we all need a self-care, I try to do that as well. So I'm still very involved in the outdoors. Obviously, when I decompress, I like to spend time with my family. I have 3 little kids, 9, 7, and 6. So hanging out with them. But yeah, very, very still involved in being outdoors, being in nature. I think it is revitalizing. It re-engages me. It recenters me. I think there's a lot of value to that continues in my own personal life as well as professionally.
Yeah, I would totally agree. I think from my personal standpoint, just the just getting my physical person into a different physical space that I've never seen or experienced before, or re-experienced because my first experience was really good. Mm-hmm. That sort of action repeated over time just really helps me in all facets of my life. Like to just go to this spot that I just want to see what this spot looks like, and it's literally changing what I'm seeing in my eyes and what my brain is seeing compared to the 4 walls of my house or the 4 walls of my office. It's so helpful to just literally physically see that and experience the everything else, that all the senses that go with that, right?
Yeah, it's that idea that we were talking about a while back, which was like it just broadens our experience, it broadens our awareness.
Right.
Somebody can go interact with nature with very little awareness, right?
Right.
Like people can just go outside and I'm getting from A to B,
right.
Not a lot of awareness.
Right.
And research says they'll still probably benefit from, exposure to the sun and exposure to outdoors. Like that's physiologically helpful. But the people who are more aware and more insightful around their interaction with nature gain even more health benefits.
Yeah.
So the difference between walking through some trees to get to my car versus walking through some trees to relax, versus walking through some trees to really center myself emotionally, right? It's the same act, but with different purposes or intention.
Right.
And the more we can be aware and intentional around our interaction with nature, the more health benefits we're going to get.
Right. Yeah, for sure. I think we could go on a whole nother journey talking about that kind of stuff for sure. If you had any other parting wisdom or parting comments for people, about mental health or just in general, what would you have?
Maybe just a little bit more down to kind of let's just talk human to human, is that, look, we're struggling. People are struggling. People have issues, and that's okay, right? We're becoming more aware that, we hear a lot of these terms. It's okay to not be okay. It's okay to struggle with certain things, and as that stigma decreases, it's becoming more acceptable. So, I guess all of that just to preface this wisdom of like, look, if you're listening and you're struggling through something or you need some help, there's people there to help you. Right. Yeah. Access to mental health care is hard right now. Mm-hmm. Healthcare is hard. Insurance is hard. Like there's so many obstacles that prevent us that potentially prevent us from getting the help that we could benefit from. And so, like, work through those, right? Yeah. Don't, there's hope. Things get better. Life can be very, very good. And there's ways to get the help. so to anyone listening who is struggling with something or knows somebody's struggling, like let's find ways to help people. To providers listening, let's find different ways to do that.
Yeah,
right?
I like that.
Let's find other ways to treat people. There's a lot going on that are obstacles to how we treat people, just as there's obstacles for patients getting treatment. Let's remove those. Let's work through those. Let's find ways to improve how we help people live better lives. And ultimately, that's the goal. That's my passion, right?
Yeah.
And any health provider, I think, at some level, well, let me rephrase that. Most, I can't say any, but most, I would imagine, at some level, got into some sort of healthcare because they wanted to make a difference.
For sure.
And along the way, systems and obstacles have kind of prevented us from doing that. And it's going to take a movement. It's going to take a lot of us, all of us, to change the way we do this and save people's lives and improve quality of lives. So this idea goes from I'm sitting across one person making a difference to then, diverting my career to technology to make a macro difference for a lot of people.
Right.
So that the individual is more cared for, right?
Yeah.
Has a higher quality of life, improves, is able to do those things that they want to be able to do. So it's kind of this circle that I've found myself realizing that it's a macro influence, but still the end goal is very individual.
I really like that.
To make a difference in people's lives. So whatever you can do, however you can do it, small things, large things, we all have different ways of doing it, but let's improve people's lives. Let's do what we can to become better as a society, to become better as a community, friends, family, coworkers. Let's do what we can to be an influence for good and remove obstacles, increase access so people can get the help that they need.
I love that, and it's pretty solid advice when the person giving that advice is taking that advice, because you were all about going around that circle of like, my goal as a clinician is to eventually help as many people as possible, and you're giving that that same advice to clinicians or anybody trying to help, is like, let's try to think about this differently to see how we can become better at it or help more, include more, be more inclusive. I think that's awesome.
Absolutely. So
say the website one more time for Videra.
Yep, viderahealth.com, Videra. It's actually a quick funny story is it actually is a derivative of the Latin word to see.
Oh, okay.
And that's kind of how we and it's also how we in English came up with the word video.
Oh, okay.
So when we talk about versus audio recording, when we started versus having video recording, we could see it, not just hear it.
Yeah.
And so when we talk about Videra Health, we're talking about seeing people.
Right.
And seeing people differently, not just in the different modality, right? Seeing people not in an office or not live on telehealth. We're seeing people differently, but we're also seeing parts of people that we weren't able to see before. We're actually getting, we're seeing more depth about what we can understand about human experience. Right. By leveraging this type of technology. So that's where Videra Health came from, Videra health.com. And just remember to see people more as humans. We're all going through this life, different experiences, different cultures is where we started this conversation. Right. See people as people. Right. And our platform can help clinicians do that clinically.
I love that. And you personally, Dr. Brett Talbot on LinkedIn?
Yes. I to be honest, I don't know exactly what off the top of my head what the handle is. But yeah.
Search him up if you want to find him.
Absolutely.
Well, thank you so much for taking the time. I really enjoyed the conversation. I think it's really helpful.
Thank you. It was a pleasure being here and just chatting with you about, you know, our experience together, what we've experienced. Talking about things we're passionate about is always a good time.
For sure. Awesome. It's done. 2 hours and 8 minutes. Well done.
Well, not your 20-minute podcast, but talked a lot.
We don't. I don't go.
Good things.
I like the long form conversation.
Well, we hit a lot of topics.
We did.
Did I do okay?
You did great.